So Andrea, it's great to have someone from the local authority. So thank you for joining us. So my understanding is that Oldham was a pilot site for the NHS the NHS funded community pharmacy stop smoking service as before it's actually scaled up to nationwide. So and you and Oldham, before this was launched, you were already thinking about adding a community pharmacy service to funding that yourselves. So I suppose I was just interested in hearing from you. What were the reasons that Oldham had for being keen on commissioning a community pharmacy stop smoking service alongside the other providers? So what do you think the strengths are of that model? Because you already had your own local authority service anyway.
Yeah, thanks, Olivia. So patient choice was our primary reason. We know that different things work for different people, and we've got really high levels of smoker prevalence in our boroughs. So we aim to give smokers as many opportunities to quit as we can. Recognise that it often takes multiple attempts for someone to stop smoking for good. So we wanted to offer this broader menu of options of stop smoking support as part of our wider tobacco control offer as our budget would allow. But why we wanted to include community pharmacy stop smoking provision specifically, and people have already alluded to a lot of this already, was in relation to the fact that residents often regard community pharmacy as a valuable healthcare service.
Yes.
It's easily accessible, they've got long opening hours, it's delivered within the community close to where people live and they work. Pharmacy staff are likely to have contact with people that may not attend formal health settings or access to traditional stop smoking or other health improvement services. So these are people that may not have other touch points, and it's that really unique opportunity to be able to engage people and offer that support. Also the recognition that community pharmacies play that key vital role in delivery of healthcare services, especially as GP and practice nurse time is scarce and it's a finite resource and there's continuing pressures on capacity. And obviously that pharmacy offer, as Robert already mentioned, has that benefit for people who wanted to stop smoking, who are also moving between your primary, secondary and tertiary healthcare services by providing that consistency and that support from that trusted healthcare professional. So there's lots of reasons for why we wanted to include that community pharmacy stop smoking provision within our range of offers. We had originally intended to commission a community pharmacy stop smoking support offer using a specification that had been collaboratively developed in Greater Manchester using that stop smoking plus model, which has the three levels of support. So, that model that suggests that every smoker is encouraged to make at least one serious quit attempt each year using one of three kind of options. So the first being that self-support for those who want to stop but don't want professional support, that brief support, and the stop smoking medicine for those who want help but not willing to commit to a specialist service. And then we're then looking at that specialist support for smokers who wanted that more intensive stop smoking support. Things didn't progress how we'd originally planned in terms of commissioning that community pharmacy offer, and they haven't done so far, but we were really, really very fortunate to be selected to be a pilot site, smoker station transfer of care. And it's meant that we do now have a number of pharmacies signed up to deliver the advanced service in Oldham, and that there is that enhanced choice of provision for people that are being discharged from secondary care. So with that cohort of people do have that range of options to be able to access their stop smoking support.
Great. That's so. So being a slight devil's advocate here, as a commissioner, what are the pros and cons of that NHS having that NHS commission service in your area? Because obviously you had this idea before of another sort of model, and I think that Alison's going to come in here as well to offer her perspective. We're going to have a sort of a little friendly debate.
Absolutely, and obviously worked very close with Alison as part of this. In terms of pros, we've got a very effective discharge pathway. We've got that robust service offer for people coming out of secondary care to continue their quit journeys. And obviously it offers that continuity of care. There have been proven quit rates and there's been really positive patient feedback. We've got some great case studies where people have tried lots of different ways to stop smoking over the years, and this has been the one thing that's worked for them. And as I've mentioned, we've obviously got that patient choice for that cohort, and it allows them to be able to make an informed decision after having conversations with our tobacco dependency smoking advisors, to be able to choose what will work best for them to be able to have their quit attempt and to stop smoking. In terms of some of the things that maybe are not so much of a benefit, we obviously haven't currently got that equitable patient choice and access. people in community can't access the pharmacy provision currently. I know that Rob's mentioned also that that's, you know, it's part of a phased approach, and, you know, hopeful that there'll be changes in the future, either via NHS or via ourselves. But there is that risk of creating a potentially maybe a two-tier system at the moment. Local authority tobacco control leads don't currently have access to the data from the NHS Advanced Service, but again, I'm aware that that's something that is looking to be resolved. So it is something that hopefully we will be able to access that information, and I know Alison will be able to provide some more context and information around that. And then also there's the potential that it may be a little bit confusing or difficult or time consuming for community pharmacists to have to bid or deliver two different services for two different commissioners and potentially provide two different lots of information and all of that. It's just that risk that we know that pharmacy staff's time's really valuable, and potentially making it a little bit more complicated than perhaps it could be if it was all by one commissioner.
And I know that one of the other issues that you'd raised was about the funding as well. I didn't know if you'd about to say something about that, because though I don't think it's led to any problems in your area, it's just a potential.
Yeah, there is potential feedback that commissioners may receive from community pharmacies if they're not able to match the same level of funding in terms of payments or in terms of training packages as perhaps the NHS Advanced Service can offer. You know, it's a very generous package that is offered, but that is due to the fact that currently the NHS Advanced Service is to be delivered primarily by pharmacists, and often locally commissioned community pharmacy services can be delivered by pharmacy technicians and other pharmacy staff, so the payments may reflect that.
No, I think it has been extended.
Anything else to add on that, though?
Yeah, do chip in, Alison. That I think it's now just been extended, hasn't it, to pharmacy technicians as well, the advanced service, which is good. But yeah, Alison, do come in.
Yeah, that's right. So technicians were included in the delivery of the Nationally Commissioned Service in April or May this year, I think. So one of the big bits of feedback from the pilot actually in Oldham was that one of the pharmacies who was most successful in delivering this service had delivered it through a non-pharmacist route. So we were really quite strong in our advocacy for that delivery of the service to be expanded from outside of the pharmacist alone. And also building on what Andrea was talking about around the amount of work that community pharmacy is delivering at the moment. If we are able to deliver that service by multiple people within the pharmacy, that just helps them to embed the service into their business as usual. So I think pros and cons, Andrea's probably covered most of them, to be honest with you. I think it's great that Oldham smokers can have nationally funded support to quit smoking, which is fantastic. It does complement the locally commissioned service, so the two services run alongside each other. Sarah and her team at the hospital will refer patients into community pharmacy or to the locally commissioned service. I think some of the cons around the service, as Andrea mentioned, is because the community pharmacy service is an advanced service. That means it's optional for pharmacies to opt to deliver the service or not. So quite often where patients' regular pharmacy is not registered to deliver the service, they don't want a referral to community pharmacy because they have a good relationship with their pharmacist. But on the positive side, if their pharmacy is registered to deliver the service, they've already got that existing relationship with the pharmacist, as Hazel talked about with her relationship with Mr. Patel. And actually with a stop smoking conversation, it's really helpful if that existing relationship is in place between the patient and the pharmacist or the pharmacy technician. So that's one of the positives around this service being commissioned at a national level.
Brilliant. Thank you very much, Alison. That's great. So I think I'm just seeing that time's ticking on. So I think we'll move on to Sarah. Could you just give us a couple of minutes from your experience of working in the trust, how you have that conversation with patients about whether they go to because you've got both services, whether they're followed up by the community pharmacist, whether they're followed up by the local authority stop smoking service. A couple of minutes on that would be really interesting to hear. Thank you.
Yeah, sure, Olivia. So yeah, it's basically, it's just about knowing your services that you're providing. So obviously the pharmacy service can differ from the community service. So it's just having a really good understanding of what each service provides. But on top of that as well, it's about, speaking to the patients case by case, and just looking at their history, looking at what they're in hospital for, their previous experiences maybe of accessing a community pharmacy or the locally commissioned service, and just taking everything into account holistically, and to think what's best for this patient, what's the best service for this patient. It may just be something really simple like the patient requires an interpreter, in which case I know that our locally commissioned service has an interpreter service. It may be just as simple as that patient has a really good rapport with their local pharmacy, like Alison has mentioned, and that, they, oh yeah, I'll go down and see him. Yeah, he's really good. Just that nice familiarity with your local pharmacy can just make it, the right choice for that patient. So it's just about, just assessing each case individually, and not really having a tick box exercise as such, but just seeing, what's best for that patient.
There's a judgment there, and you're sort of having that conversation collaboratively with the patient as well.
That's right, yeah. And, and telling them what's on offer, and knowing your service, and then just sort of jointly deciding what's the best option.
Perfect. So this is, joy to my ears. Yeah, it's wonderful. Sounds great. So in our last couple of minutes, I was wondering, Alison, I know that you were involved with the Oldham pilot, which I think reached about 12 pharmacies, and then that grew some more, I think, to about 30. And now you're moving it across the patch. So you're working with about 300 pharmacies. Now, you heard from, which is massive, and I think probably unlike other people doing, but that's just because you're so far ahead, having been involved in the pilot. But obviously, to start with, as Alina was kind of really demonstrating, it's very hands-on, but obviously there's got to be different strategies as you move to scale. So I wondered whether you could just give us a few of your top tips about perhaps not most people won't be working with such large numbers as 300, but they might be working with 30 or 35, for example.
Yeah, thanks, Olivia. So you're right, with Oldham, we started with 12 pharmacies. We've now got 30 pharmacies providing the service in Oldham. But when we look to ICB level, we've got 10 places within Greater Manchester. So we've got just over 300 pharmacies across Greater Manchester who are now set up to deliver the service. So working at scale has been very important. When we were working at a very small scale, we were quite hands-on in supporting the pharmacies in terms of the referral pathway and helping them with delivering consultations with patients, because we'd gone from no pharmacies not being able to deliver any stop smoking services at all to having these 12 pharmacies up and ready to go. So the way that we were engaging with pharmacies obviously needs to change. You can't be very hands-on when you've got kind of 30 pharmacies, and certainly not with 300 pharmacies. So it's looking at different ways of engaging with the pharmacies to make sure that they're aware that this service is being provided. So there was lots of work that we did jointly with the LPC around communications, so email communications out, pages on the LPC website to keep everybody updated as to what was happening with the different trusts across Greater Manchester when they were due to go live. We did a series of webinars jointly with the LPC and with the CSU in the evening to engage the pharmacists, to let them know when their local trusts were going live. We had the Trust Tobacco Dependence teams on those webinars, as well as the CSU and the LPC. So it was a real collaborative effort. And we repeated that message each time a trust went live, just so that everybody across Greater Manchester was aware of what was happening. Lots of email communications, as I mentioned. We also did a little bit of a due diligence exercise for each trust before they were going live for the pharmacies, because, as Rob mentioned at the beginning of the session today, it was a soft launch, so registration opened for the pharmacies back in March 22, but some of our trusts in Greater Manchester didn't go live until the back end of 22 or kind of January, February this year. So a long time had passed between when a pharmacy had registered to deliver the service and when they were actually going to be receiving referrals. So we did quite a bit of work in the meantime to make sure that they were still wanting to deliver the service. They still had trained practitioners in place, because obviously there's some turnover of staff and that sort of thing. So really it's thinking about working at system level has been really beneficial in Greater Manchester for us, and having access to the data that Andrea mentioned. The local authority commissioners unfortunately don't have access to the data at the moment. That is something we're working on as an ICB.
I might stop you there. It's wonderful to hear more, and I think if you want to hear more from Alison, do go into the breakout room, which we will do in a moment after we move to our next item. Thank you very much, Alison, Sarah and Andrea.